Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Welcome to this lecture. And in this lecture, I'm going to talk to you about gastrointestinal diseases. And the aim or the main objectives of this lecture is to understand the pathophysiology, clinical presentations, and oral manifestations of different diseases that affect the GI system. The gastroesophageal reflux, GERD, the hiatal hernia, peptic ulcer disease, inflammatory bowel disease, and celiac disease. So let's start with the first part. And in this part, I'll talk to you about the diseases that affect the upper digestive tract, mainly the esophagus. So the gastroesophageal reflux, or GERD, is the most common disease that affects the GI system. It affects almost 10% of the population, which is a very high percentage. And the reason or why GERD happens is that there's a relaxation. Sorry, let me correct this. Okay, so there's a relaxation of the lower esophageal reflux, the lower esophageal sphincter, which is the sphincter that connects the esophagus with the stomach. And because of the relaxation of this sphincter, acids can go back to the esophagus, which we call it regurgitation, which means that the gastric content, which is highly acidic, will go up into the esophagus, inducing or damaging the esophageal mucosa, because the esophageal mucosa is not prepared to this low pH. So this would induce damage and ulceration in the esophageal lining mucosa, and with continuous exposure to acidity with continuous ulceration in the esophageal mucosa, this will lead to strictures, fibrosis in the esophagus, and it will also induce some epithelial changes. We call it metaplasia. And metaplasia, it means that there is a change in the type and shape of the cells. There is no malignant changes, but there is sort of reactive physiological changes within the cells. So the esophageal cells will become more of a cuboidal in shape, and we call this Barrett's esophagus. It was shown with the studies that with the long-term exposure to the acids, and these metaplastic cells might convert into cancerous cell due to repetitive term of exposure to the acids. So this is what we are talking about. This is the normal stomach with a normal sphincter here. So the acidity is maintained within the stomach lining, which is prepared to handle this level of acidity. However, in GERD, there is relaxation in this esophageal sphincter, which allows the acidic content to go up into the esophagus, inducing changes and pain and burning sensation in the esophageal mucosa. Right. So what are the symptoms? How it is presented clinically? The patient will usually complain of a burning sensation known as heartburn, and sometimes epigastric pain. This pain could be referred to other part in the chest, and sometimes to the left arm, which mimic MI attack. So this is one of the reasons that patients head to the emergency department thinking that they are having MI attack. In fact, it is just a GERD. It's a epigastric pain caused by GERD. And of course, regurgitation, where the patient feels the acids going up into the esophagus. Many of the conditions are clinically silent, which means that the patient would not feel any of these symptoms. There is no heartburn, no epigastric pain, no regurgitation. However, you might be able to detect this disease or diagnose this disease based on the examination of the oral cavity. So you might notice lots of erosions affecting the teeth, mainly the palatal surface. Another thing is you can see an exaggerated attrition of the teeth. So because of the acidic environment within the oral cavity, induced by the regurgitation that is not felt by the patient, this low pH would make the enamel softer, and it would make it more of more affected by the attrition forces, and usually you will see this as sort of a saucerization of the attrition or the wearing facets. Another symptoms that the patient might complain from is feeling the lump sensation, as if there is a foreign body in his throat that he cannot swallow or cannot get rid of. Chronic cough is one of the main presentations of a silent GERD. So the patient might go under several investigations, doing chest x-rays, seeing different doctors, just complaining from chronic cough, and it turns out that this chronic cough is related to GERD or increased acidity. Hoarseness of voice. So these might be some of the clues that the patient is having a silent GERD. The last one is the presence of iron deficiency anemia that is not explained. The patient is taking adequate dietary. There is no reason for the blood loss. There's no heavy periods, for example. So there is no evidence of loss or lower intake of the iron. Still, the patient is having anemia. So it is possible that the patient is having GI problem. One of these are GERD, inducing erosions in the esophagus and continuous bleeding, low level of bleeding that is not detected by the patient until after a long time goes by, so the patient would develop iron deficiency anemia. So these are some clues that the patient might be having GERD. How to deal with the GERD? Just using simple antacids that would relieve the heartburn. Sometimes we might need to take more actions by using H2 receptor blocker that inhibits the acid secretion, or we might inhibit the acid production in the first place using proton pump inhibitor. Proton pump inhibitor are more recent medications like omeprazole or lansoprazole. They are becoming more favorable than cimetidine or other ranitidine or these type of H2 receptor blockers. How to manage the dental erosion? So of course you need first to deal with the condition. You might advise the patient to see a GI specialist to confirm the diagnosis and prescribe the proper medication for him, whether H2 receptor blocker or proton pump inhibitor. Then you need to deal with the acidity in the oral cavity using rinses of baking soda, and this would reduce the acidic environment in the oral cavity. Apply fluoride on the teeth. This would also make it more resistant to erosions. Surgery usually is not a treatment for GERD. Usually it's more relying on medication, proton pump inhibitors or cimetidine or H2 receptor blocker. They are the mainstay treatment. However, in complicated cases where stricture happens, in this case, surgical treatment would be indicated. The second condition that we'll be talking about is hiatus hernia. And in hiatus hernia, it means simply there is a herniation of the stomach through the diaphragm, and so the part of the stomach is actually present in the chest, close to the lung. There are different types of hiatus hernia. This image showing the normal stomach. So this is the esophagus. This is the diaphragm, which is a muscular structure that would control the movement of the stomach. So it is just below the diaphragm. When there is a bit of loosening or weakening of the diaphragm, the part of the stomach might be able to go up or above the diaphragm, and in this case it might go up and down, so it might keeps moving, or sometimes when it is really big in size, it just got stuck within the chest cavity. And it is, to confirm the diagnosis, you need to do a barium swallow and endoscopy. This would confirm the diagnosis. So this image here shows the barium swallow. So the patient would swallow a capsule containing the barium that would provide the contrast material, and by taking X-ray it will show that this is the stomach, and this is part of the stomach is actually located over the diaphragm, and it is located within the chest cavity. How does the patient feel with the hiatus hernia? He would feel similar symptoms to GERD, but it is far much more severe, with a severe persistent epigastric pain that the patient also might go to the emergency department thinking that he's having MI or something, and with this barium swallow and endoscopy possibly, they can confirm a diagnosis of hiatus hernia. How it is treated, just trying to, again, the doctor usually try to avoid doing surgical treatment unless it is really necessary, because it is really complicated working with the muscular diaphragm and the chest cavity. So they rely on reducing the symptoms by reducing anything that cause pressure within the abdominal cavity that would push the stomach up to the chest cavity. And so the patient is advised to reduce weight if he's overweight, and is advised to eat small amount of food, not to eat a big meal at once, reduce the fatty food, to try to sleep while the patient is, has in semi-upright position rather than a supine position, to reduce the chances of the stomach to go up into the chest cavity. Not wearing belts or anything that put pressure on the abdominal cavity. So all of these, measures aims to reduce the abdominal pressure and hence reducing the chance of the stomach to go up into the chest cavity. Sometimes they do massage exercises, just try to get the stomach down to its place just below the diaphragm. Regurgitations, GERDs, and these symptoms can be managed with PPI or H2 receptor blockers. So this is the end of the first part. The second part we'll be talking about diseases that affect the lower digestive tract. See you then. Thank you. Bye-bye.